So the recent test that we did was when Professor Angela Vincent, who is an immunologist at Oxford, she came here and we did discuss this case with her, and she agreed to take a serum sample, and she said it could be an NMDA receptor antibody disorder. And then we had a report saying that it was weakly positive. So again, we are looking for a diagnosis. She's asked us to repeat the test when there's an exacerbation of symptoms and possibly also a CSF, though these antibodies are more prevalent in the serum. So coming to the treatment, initially she was untreated for 3 months. In 2010, she was started on antipsychotics, topiramate. There was a poor response to symptoms, and then clozapine was started in December 2010 along with many other medicines. In 2011, there was a persistent of psychotic symptoms, so clozapine was increased and topiramate was at 100 per day. And then she was treated for the pleural effusion that I talked about. And then olanzapine was added along with nootropic and frisium and supplements. And she came down in July 2011 to meet Dr. ESK. And she went through more investigations. And she was worked up for Wilson's, which is a problem with the copper metabolism. So there was no KF ring, though there were some tests which are positive later. In 2012, there were some improvements with cognition, with psychotic symptoms, but there were some odd behaviors. So levetiracetam was introduced at 500 milligram. And then it was noticed that there was a lot of self-talk and perioral movements. And then this was stopped, the levetiracetam was stopped, and topiramate was restarted. So we also looked at rheumatoid arthritis because of the dystonic posturing of the fingers, and that was negative. So then we thought it could be a possible atypical Wilson's. And then we put her on a trial of penicillamine, started at 500 milligrams and went up to as much as 2 grams a day. And she did develop some skin pigmentations on the chest and the back, and she was treated for that by a dermatologist. And with the penicillamine, we found that there was some improvement in gait and self-talk. So this is how it was started, increased to 1 gram a day, and now she's on 750 milligram. So we had some tests which we thought could be suggestive of Wilson's. So we had raised serum copper on 2 occasions, in 2013 and 2014, but the rest of the tests were bang normal. The 24-hour urinary copper was normal in 2013 and 14, and ceruloplasmin was up only in 2014. The rest have been normal. Quickly take you to the psychological assessments. It was done by Yogini. So the family had moved several times because her father had a transferable job, and she was a good student. She was shy, she had few friends, and she had to stop mainstream schooling because the illness started, and presently she's in a special ed school. And she was assessed at various points from 2010 to 2014. So in the beginning, she was assessed for behavioral problems, and she underwent cognitive behavioral therapy counseling that was elsewhere, not with us. The personality measure showed that there were no psychotic features at that point. She was depressed, she was moody, ambivalent. There was a mixed anxiety-depressive state, according to anxiety depression measure, low self-esteem, and felt rejected in school and restless. They were parents, her parents were like any other parents, protective and rewarding, punishing as per the requirement. And they were counseled about being realistic about the outcome. and they were reassured. 2011, poor academic performance. Again, the movements, delusions, the stares. IQ could not be administered because she's not been really cooperative, restless. So we continued, the therapy was continued elsewhere, not with us, with psychoeducation for the family. 2012, she was with us, underwent CBT. Second half, 2012, they went away, quite a bit of doctor shopping because they wanted the child to get better soon. And we understood that, and they disappeared. They never came back for review for a while, and that was the time when she did very badly. There was an exacerbation of symptoms. And then 2013, there was an introduction of penicillamine, and there were improvements in gait. She was more cooperative. The involuntary movements persisted, and the psychosis and abnormal behavior were present. So the psychoeducation assessment in 2014, some improvements in behavior, but the self-talk muttering continued. And she used to get very angry when she is hungry. So she'll get very physically aggressive, and we had to be very careful. So we had to see that during assessments, we never posted very long assessments, and we let her go out and have a bite before we went on with the next assessments. So the cognitive functioning showed that she had very low scores on perceptual reasoning, working memory, processing speed, severe cognitive difficulties. And presently she is at grade 1 level, that is what she is back to and she is studying. So like I said, the first half she was cooperative, she was able to focus. The second half, she just refused to, and we had to stop the assessment. So this is how, it's a snapshot. So we plan cognitive and behavioral therapies and counseling for the parents. And many of the difficulties persisted, though we found that there were some improvements in some areas. So as I said, we did a multidisciplinary assessment. So we have a presentation from Mr. Yuvraj, a senior physical therapist, as to how we assessed and how we went about the therapy for her. Yuvraj.
Good morning, everybody. When the child first came to us, we did a neurodevelopmental assessment. In assessment, we did motor assessment. In this, we could find out that proximal joints range of motion was mildly limited, and the muscle tone and power was normal, and there was some involuntary movements of the fingers, mainly the thumb, and also she had involuntary movements in the head, and coordination was fair, and good grip, grasp and reach, and fine motor skills was good. The handwriting skills was fair, and the aerial was independent, and the balance was good. And she had some gait problems. I thought the gait problem must be because of her overweight, and the treatment we have given is neurodevelopmental therapy, and in that we gave exercise program and positioning, joint compression, and then we gave her some stimulation. This is transcutaneous electrical nervous stimulation. This is for the hand muscles to improve the intrinsic muscle activity, and handwriting developmental therapy. So we concentrated on 3 therapies. First one is neurodevelopmental therapy, and next one is handwriting developmental therapy. The last one is OT skills training, that is attention skills training. And in handwriting development therapy, we gave her the coloring with the crayons, writing training, and then initially, and then writing a small paragraph. We started with the small words, then afterwards the paragraphs. And then in attention skills training, activities like beadings in different manners. We'll ask her to collect the beads with different types of colors and in sizes like that, and collecting things and placing in the allotted place. And this will be having a hurdles. For example, if I ask her to do an activity, we can take an activity as a beading activity. So the sting will be in one place and the beads will be in one place. I'll ask her to take the beads in what color I'm asking her to do, and I'll ask her to go and sting in the thread, Between that, in this gap, we'll be having the certain hurdles. There is jumping and also writing the numbers, how many times she's going and doing the activities like that. And duration of this treatment was 45 minutes daily, and this was given for 20 days. And the outcome was the following: the fine motor skills, in treatment in 3 to 5 days, initially she was highly resistible, she didn't do anything actually, and after 5 days she slowly picked up, and the fine motor skills, the handwriting skills improved, the coloring pictures improved, and she is able to sit in one place for more than 15 minutes but only with the verbal prompts, and started to carry activity with only with prompting. And cognitive and perceptual skills, her eye contact improved a lot, but she's not maintaining it for some time. And attention span is enough to carry out a task with verbal prompts. And behavior issues, she was obedient during the session. Self-talking, unwanted facial grimaces, it persisted. And at times anger seen, and screaming was reduced, and restlessness was still persists. Social skills, ability to express for her needs is good. Mingling with peer group is very poor. And language and communication, self-talk still persists, and communication was improving. And self-care, good toilet training and wiping mouth, etc. And then the gait also improved a lot. She used to just waddling like that, and then after some time the gait was improved, and mainly the handwriting skills, it slowly improved. So these are the outcomes we could see. Thank you so much. Now we call upon Mrs. Shubha, child counselor, take over.
Thank you, Yuvraj. Virita has been a challenge to us from day one when she walked in for therapy. She was a normal child attending a normal school, doing extremely well. Even then, when she was in the normal school, she didn't have too many friends. She had a couple of friends with whom she was extremely close. But what was very strange was that she was among the top 5 in class and with excellent social skills. When she came to us the first time, she was extremely resistant to any form of therapy. She would refuse to sit down. In fact, I remember Virita would keep walking in and out of the session. You know, she would walk in, walk out, and she expected the therapist to do the same. I had to walk in and walk out with her every time she left the room. So first few sessions were strictly rapport building because I couldn't get her to sit down, listen to me, or even look at the activities I was doing. Once she settled down with neurodevelopmental therapy, her sensory issues started settling down. We found that in the behavior therapy also, there was a change. She started sitting down in the room, she started listening to me. The general therapeutic techniques we used were token economy, behavioral chart, and I remember when we started with the behavioral chart, she was extremely gung-ho, she was very happy. Every time she got 5 stars, there would be there would be lot of exhibition of happiness, shouting, screaming, hugging. But later on, at one point, behavior chart reached a saturation point. We used modeling. She always wanted a role model of her own age. So we kind of got one of her close friends, brother or sister, to sit down with us in the therapy sessions. They were used as role models as to how you should model your behavior, what should be your social skills, how should you interact with people socially. We had play therapy. Play therapy, we actually got to learn a lot about the family dynamics as to how her uncles played a huge role in decisions taken in the family, and how her mother listened to her uncles. To a very large extent, her father kind of was a little laid back. So these things came out, and these family dynamics came out during the play therapy. Then we had a peer mentor who was her brother. She is extremely close to her brother, very fond of him. So whatever he said played a very important role in her life. Then we had, therapeutic techniques were used for concentration, like letter cancellation, trail making, pencil shading, and we used music because Virita enjoys music. Any kind of background music played, Virita will immediately sit down. She will ask you about the song. She will ask you questions about who has sung this song. And she has a couple of favorite Telugu actors like Mahesh Babu and Allu Arjun. If you download their songs and play it, you're assured of 100% attention in the therapy, till the therapy is over. But occasionally we find that her repetitiveness, used to take charge. She would expect the same song to be played again and again. So at one point, if you try to break the routine, you're assured that there would be a kind of tantrum during the therapy session. From June 11th to August 11th, the course of therapy was for a very long duration due to inconsistency. The client's parents were looking at other options like aromatherapy and acupressure. She showed improvement in the following areas. ADL. ADL was a very huge issue with Virita when she came to us for therapy, and we administered ADL training with her. Attention, her peer interaction improved, but what is surprising is her peer interaction improved only with people she liked and associated. So during group therapy sessions, she had a few favorites with whom she would sit down and do the group therapy activities. But if you change her from that group to another group, the entire group therapy session had to be suspended. Improved eye contact, her aggression was considerably lower. The client came in for therapy after a year's gap. She was under therapy from December 12th to February 13th. And at that time, we found that her disinhibition had increased. And like Rama said, she said, I was a boy, and she would dress like a boy. She would walk like a boy, and in fact, she would bully people in the group sessions like a boy. At that time, there was increased obsession with WWE. She used to watch a lot of it, and it would be replicated in the therapy sessions. At times, she would say, come, let's fight, or let me attack you. During this, self-talk had increased, so had her aggression. During the second course of therapy, what worried us was her obsession with the neighbor's son. It still continues. And that led to a lot of problems for her mother socially. She was kind of ostracized. She wasn't allowed to mix with other kids. And the mother found it very difficult as they live in an apartment. Frequently, Virita would be told not to come out and play. And that actually increased Virita's aggression at home because she felt it was her mother who was responsible for keeping her at home. She had cognitively improved and was capable of comprehending complex instructions. Current behavior profile, Virita has shown marked improvement in her cognitive ability, social skills, peer interaction and eye contact. Disinhibition and aggression, self-talk still continues. The caregiver also shared that the ADLs have improved, so has her concentration, retention and speech. Now what we find at the behavior profile is that Virita is willing, as long as she has a break in between for food or a break in between for a snack. Virita is very cooperative. She's willing to comprehend instructions, and we've seen improvement in that. I'd request Rama to take over.
I'd like to share a video with you. This is with the consent of Virita's parents, and so that you can have a look. And like I said, it's for your inputs.
if you don't go to school, she'll call Rama auntie and she'll scold her. She'll scold Rama auntie. She'll call Rama auntie every day, calling her. Okay, tell me all your friends' names, Vinita. Bhanupriya. Bhanupriya. Shubha. Shubha. Lavanya. Lavanya. Mahalakshmi. 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 Two Mahalakshmi, sir. One or two? Two. Okay, yesterday what all did you do in school? Very old moments.
Yeah. So she's plateaued in terms of improvements in psychotic symptoms. So a lot of blinking here, as you saw in the video. There are perioral movements and self-talk, a lot of muttering, and some paranoid delusions. So there are behavioral problems, not much of improvement in cognition, and the counts have kind of settled. They're much better than before, and she continues on the D-penicillamine, the topiramate, the shizopin, and like I said, we have a weak positive NMDA receptor antibody. So that is where we stand now. We request Professor Vedanarayanan to